Okay. So my topic is phacoemulsification in post-RK eyes. Now, RK that was done around 20 to 25 years ago in patients, those patients are coming back for cataract surgery. Now, when we all know that RK is a complicated surgery in terms of looking at the number of cuts that are made on the cornea, probably some of them going 90% depth. And it is an eye, it's like I can't call it a gift, but it's something that keeps giving. So the corneal structure keeps changing throughout life. And it does so even after phacoemulsification is done. After putting the IOL, the story is not over. In fact, it begins when the patient walks into your center. So I can't move the slide to the next one.
Can you check?
Okay. So there are various challenges that we face in post-RK eyes. The astigmatism is irregular. There is an altered corneal biomechanics. So in RK eyes, the central area becomes flat. It's different from LASIK. When we are calculating in any patient who is a post-refractive patient, it's very important to understand that the doctor and the patient both can get a surprise. That when you calculate or measure on any biometry device, optical biometry is obviously supposed to be superior amongst all biometries done, but you'll get a different astigmatism with every machine. So irregular astigmatism and altered corneal biomechanics, the central portion is flatter, so you get an overestimated power. Precise IOL power calculation is very complex. Every system will give you a different reading. IOL master will give you a different reading. The Antirion will give you a different reading. Pre-RK power is important. Number of cuts is even more important. So there's a rule of thumb that we go by which says that if there are 4 cuts, you're supposed to target a half or a -1 diopter target. If it is 12 cuts or more, then it goes to 2 diopter. Now, you have to note the area of scarring. If the scarring is right at the center, then you have to counsel the patient accordingly or plan a separate procedure for the cornea. But if the scarring is mostly along the cuts, then you can go ahead and prepare. And also, it becomes a little more easy, and the corneal astigmatism is a little more regular when the scars are deeply in place. Prepare for post-operative surprises. You have to prepare the patient for expectations. These patients sometimes come with expectations for premium IOLs. So IOL selection is very important in such cases. So there is a central flattening, a hyperopic shift. Unlike LASIK or any other PRK that is done after RK, calculation of IOLs becomes difficult. Now, the RK is the surgery where anterior and posterior curvature both are altered, not only the anterior curvature like in LASIK. So we flatten the center of the cornea, so there's a hyperopic shift. As I said, rule of thumb, 4 cuts -1 diopter has to be targeted, 8 cuts -1.5 diopter, and 12 or more cuts -2. Now, choice of IOL. We would prefer only a monofocal, or if the astigmatism is fixed and it is little consistent, then monofocal toric IOL. Some cases, EDOF case patients do well, but you have to explain expectations. You have to explain to the patient that it may not work completely like an EDOF, mostly like a monofocal. Multifocal and trifocal, I would not advise. It does lead to a high degree of astigmatism leftover, post-operative surprises, and the patient is never happy. So this is a patient that we had. Actually, this is post-RK plus LASIK. So RK was done, leftover astigmatism and power was corrected with LASIK. But just considering the RK point of view, the axial length is 24, the astigmatism seems quite regular. So we went ahead and did an ASCRS calculation. I rely a lot on that. But we take a target of -1. The number of cuts of RK were taken into consideration. We got an average power of around 24.7 or 25. So we took it as 25.5 with a -1 target. I wanted to leave it a little more myopic, because there's going to be a continuous hyperopic shift throughout her life, as I said. We went ahead and did the surgery. Now, surgical aspect is very important. Now, when we are understanding that RK is not compatible with multifocal IOLs, we've decided the IOL power calculation is perfect, but the surgery is equally important. Now, if there are cuts which are placed haphazardly, you need to take your keratome and measure. In between the 2 cuts, you need to place your keratome. If you place the incision on the cut, you may unzip it, and that leads to a disaster. So while the surgery is happening, you need to place your ports accordingly. If you're planning a toric IOL, you need to place your incision accordingly. You can pre-plan the incision. In case these eyes are being considered for femto surgery, it can be done, fragments can be made, but in the area of cuts, mind you, there will be no fragmentation. The laser will not be able to go through. Do not try to do a rhexis in such cases with femto, because the rhexis will leave behind tags. Wherever there are RK cuts, the rhexis will not be able to be made by the femto. So now I have placed an incision in between the 2 cuts. obviously, if the cuts are irregular and you cannot find a place where the keratome can be wedged, you have to take a scleral incision. Scleral incisions always hold better. After having performed the rhexis, then it's like any other surgery. You go ahead and you do your cataract. Now, I would also like to suggest that the parameters should be a little low. Do not keep the bottle height very high. Any undue tension in the eye or any stress that is put on the cornea can lead to edema of the cornea later on or in the incisions. The RK cuts do swell up. There is little corneal edema sometimes after surgery if there is undue pressure put on the cornea. Also, these are myopic eyes, so you have to consider that the bag is deep. The eye will deepen when you try to keep continuously increasing the bottle height. Now here, it's a femto case, and we have placed our incision. This was more than 10 cuts. So here we have, as you can see, I'm taking my side ports. Just speed it up a little bit. Yeah, so the incision has been made. A careful, controlled incision. You should not decompress or tighten the chamber too much. So as you can see, a rhexis has been made with a femto, but there are a lot of tags. Now the thing with femto is it will give you the perfect rhexis, but if the tags are left behind, the tags will rip and that can cause an extension or a tear. So wherever there are tags, that is a danger spot in femto CCC. So after the results, you can get such results of 6/9 unaided with an N6 with a plus 2.5 add, only if we follow all these meticulous steps. It's important to note that even after the surgery, the patient can have a little edema of the cornea, can have a little hyperopic shift that you can see, but slowly and steadily they settle down. If you target a high myopic error, like around -1 or -1.5, they do settle down to plano, but you may obviously see over a period of years them settling down to around 0.5, plus 0.5 or plus 1 also. So this particular patient did very well with us. So yeah, that's it.
Very nice presentation, Shivani. Only thing is I find that I saw in your video that you're putting more clear corneal incisions.
Yeah.
But what I would suggest is I would put more of scleral. Go in the posterior limbus or even behind that and go more scleral. And the dictum I follow is that as little incisions into the eye as possible. So I do only coaxial even otherwise. So I have just 2 incisions. So my main port incision sometimes is 1.8 only or even 2.2. And the side port is only 0.5. Yeah. So as little incisions into the eye as possible. Yes. And with the catalyst, I don't find any problem in making the rhexis with RK. I think Zemer there's a problem. I'm not sure because Ramu, you are using both, no? Catalyst, I didn't find anything because most of the cases I moved to.
I would tend to agree with Shivani. It's just that those corneal RK, they are scarce, and laser doesn't, irrespective of the machine that you use, the laser doesn't go through those areas. So as she did, whenever I'm using a post-RK case, if we are doing a LRCS, then we use the bent cystitome and then gently gather up because invariably there can be some areas which are uncut over there. But adding on to a nice presentation, I would say that the challenge is really the calculation of the intraocular lens power. Yeah. And we generally go by the Barrett-Truquet formula. And the Barrett-TK toric as well as Barrett-Truquet toric, which we can use for laser vision correction, does not work in this. And it's only the Barrett-Truquet which works. And that I find gives reasonably reliable results. Some of these cases have a significant amount of astigmatism, and whether to, of course, as you said, multifocals, trifocals are generally we don't consider them. But to correct the astigmatism, the simple dictum we follow is that if the patient was having good quality of vision with spectacle correction, then we go ahead and correct the astigmatism with toric intraocular lenses.
That's true, sir.
But if the patient needed a semi-soft or a rose scale lens because the high amount of high-road aberrations, then maybe staying away from toric intraocular lenses is a good idea. As far as the incisions are concerned, I mean, if it's a 16 cut to a 32 cut RK, as Mohan said, we'd go for a scleral incision. Otherwise, it's a 4 cut, 8 cut, clean cut RK, then going between the incisions also, as you did, is a good idea.
Yeah.